Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive. Hello, I'm Dr. Hal Stewart. This is Health and Harmony Beyond the Teeth. We're so glad that you're here with us today. Today we are having our Part 1 series with Dr. Steve Lamberg, the author of Treat the Cause, Treat the Airway. One of the most profound books that I've read because it deals with treating root causes of what ails us. And Western medicine and in dentistry, we're really taught to treat symptoms and put Band-Aids on things. And the pharmaceutical industry is what it is because of that very reason. Now, I'm not saying that we don't need pharmaceuticals and we don't need drugs, but it is this humble doctor's opinion that they're overused greatly in this country, if not worldwide. Dr. Lamberg, I introduced him last week in our overview of this 4-part series, and Dr. Lamberg has spent quite a lot of time researching the effect of poor breathing, poor sleep, and the effect that it has on our entire body. And so simply by improving our sleep, improving our breathing, we can arrest a lot of diseases that are chronic diseases that affect people. So it gives me great pleasure to kick off this Part 1 of a 4-part series with Dr. Lamberg, and I'll bring him in now. Dr. Lamberg, welcome. It's good to have you again, and I'm really looking forward to this series of about your book. So I'm going to let you kind of take it from here.
Thanks, Al. Thank you very much for having me, and that was a really perfect introduction. You kind of summarized the whole point of everything, that we spend too much time treating symptoms, consequences of airway problems. So eventually I ended up making a questionnaire for all the medical conditions, and finally I was asked to write an explanation, or in other words, an interpretation key for the questionnaire. Why do I ask these questions? And we're going to take you through the whole book in 4 parts. So the learning objectives are going to be, you will learn how to screen for airway and sleep disorders from a medical history using the Lamberg questionnaire. You will learn the value of using the Lamberg questionnaire as a communication tool, and it's going to help motivate your patients to seek more comprehensive health. So the value of the screening questionnaires are really a little bit deeper than you think. Part of it absolutely is to screen and find out who has a problem. But then on the other hand, it's to educate. If you ask a lot of questions about someone's health history, they might not have problems, but their wife or their husband or their uncle or their parents might have problems. So you're educating these patients about the people in their orbits. And so then they'll come maybe and seek out your expertise. It's also for advocating, and this is a political thing regarding insurance companies and how larger medical groups handle these patients. Are they going to continue to treat symptoms with drug companies, or are they going to stop and realize that you can treat one system, but then another system is going to be problematic if you fail to address the problem that's causing the issue at the beginning? So it's not unlike in a coal mine, the coal miners bring in canaries. They bring in a canary. If the canary dies, they know there's something wrong. They don't try to save the canary by resuscitating the canary. To them, that's a message. That's a sign. It's a red flag, or it's a canary. And that tells them that there's carbon monoxide. So in my opinion, medical conditions are our dead canary. There's sleep-related breathing disorders, which cause chronic inflammation, and chronic inflammation causes medical conditions. So there's multiple pathways. One is the chronic intermittent hypoxia or lower oxygen levels, and the other is fragmented sleep. Both cause activation of the sympathetic nervous system. So there's an inflammatory response, and there's two types of inflammatory responses: acute, which is always good, and you get the pro-inflammatory cytokines, and there's a whole bunch of them, and they help healing. But if it becomes chronic, if inflammation becomes chronic, they become upregulated, and that's what leads to the problems. It's your own immune system which causes the problems. So we have two parts of the stress response of inflammation. One part is sympathetic. It's the fight or flight response. And there's adrenaline, increased heart rate, increases the airway, reduces the non-essential functions like decreasing lymphocytes and blunting the immune response. There's stress alerts the amygdala, which sends message to the hypothalamus, sends message to the adrenal glands, and you get adrenaline in your body. And then there's part two, the hormonal, and this relates to the HPA axis, the hypothalamus pituitary adrenal axis. Once that's activated, the adrenal glands release cortisol. So together, the autonomic nervous system, that's the sympathetic parasympathetic part, and the HPA axis, they work together, and they produce a state of biologic and behavioral preparedness. So evidence supports that they cause, the sleep-related breathing disorders cause chronic inflammation by the two pathways. Chronic inflammation, though, is the cause of most medical conditions. Therefore, sleep-related breathing disorders cause or are associated with most medical conditions. So you can see here we have sleep-related breathing disorders, which lead to chronic inflammation, and then the systems are taken down. The medical conditions that we see are the canaries. So if we're going to treat these people, we're not going to just put everybody on CPAP or oral appliances or give them medications. What we want to do is find out not just that they have a problem, such as sleep apnea, but we want to find out what is the cause of the sleep apnea. Is it an anatomic problem? Is it a physiologic problem? Or is it perhaps just a behavioral problem? Like, how do they use their airway? Then we can have targeted treatment and cure the breathing problem and reduce the inflammation and heal the system. So sleep-related breathing disorders, again, if people are more graphic learners, kind of right brain people, this is kind of the feel here. You got intermittent hypoxia and sleep frag activates the sympathetic nervous system here. You get the HPA axis going too. Increased cortisol can cause insomnia, and that leads to sleep loss, insulin resistance, metabolic syndrome, gain weight, obesity, and then that it's a cycle. It goes round and round. So if you just want to put this, burn this into your brain, it's just a simple way to look at it. So this is the Lamberg questionnaire, which is available to everybody. It's free. You can just go on my website, and I have a little, the link for the website is right at the last slide of each part. So you can just go to my site, drlamberg.com, and you can download this for free. These are your canaries, okay? So when you look at a medical history, you have to start thinking, how did they get that? How did they get these problems? How do they have high blood pressure? How do they have difficulty breathing during the day? Why do they have reflux? Why do they have tingly hands? Why do they have diabetes, type 2 diabetes? So these are all problems that, that we don't necessarily associate with airway. And the book is about the relationship of all these problems and the sympathetic nervous system and airway. And this is the book, which is on Amazon Books. So it's easy enough to find. I'm sure everybody buys books, either Barnes & Noble or Amazon. And this is the title of the book, and this is what it looks like. So in order to determine the treatment targets, we have to collect the data. Therefore, data collection is the key. And I'm going to say it again, it's the key to treating anything. You can't just treat everything just because they have obstructive sleep apnea. You can't launch into treatment. You have to find out what's causing the apnea. It's almost like a two-step process. So we have a data collection in our office that's run by this navigator, and we have a newer version of it, actually. It's a version 15 right now. But just to give you the idea of this, we have anatomic, physiologic, and behavioral data. And my staff collects this. We do a cone beam on them. We look at their tongue range of motion. We look at their expiratory volume of air. That's surrogate for lung volume. The PNIF is peak nasal inspiratory flow, and we want to see exactly if they have a nasal obstruction. And this is how we do it. We don't just guess and give them some appliance. We're trying to find out, is it the nose? Is it the lung size? Is it their tethered tissues? We do a cone beam to see if they have other problems, enlarged turbinates or deviated septums, enlarged swell bodies. Where's the hyoid bone in relationship to the mandibular plane and the minimum cross-sectional area? So these are great tools. It's a matter of putting all this data together. Once we have it, I take it on my thumb drive and we mail it to the ENT, and then they do an endoscopy. And so between the cone beam and the endoscopy, we can kind of dial in on these patients and see what their problems are. So the questionnaire is based on 19 categories, and the first one is the standard questions. The standard questions are really simple, and this is pretty much what the Stop Bang is about. There are some validated questionnaires. The Lamberg questionnaire has not been validated. However, it's going through, there's 2 universities now looking at it, and they're interested in validating the whole study. It's a really big job. It's probably close to $1 million to do a validation study on a questionnaire. So using the Stop Bang questions, we want to know things like, do you awaken unrefreshed or feel sleepy during the day? Is your snoring loud enough to disturb others? Have you been aware of your snoring for a long time? Have you been told your breathing stops while asleep? I mean, these are painfully obvious questions. Do you ever wake yourself from sleep feeling that you are choking? Have you ever had a sleep study? Have you tried CPAP? And if the pressure in the CPAP was over 10.5 centimeters, that's an indication that these patients are going to be maybe non-responders to oral appliance therapy, because it takes that much pressure in order to maintain the airway with the air splint. And is your body mass index greater than 27, or is your neck bigger than 17 or 15.5 for women? And do the edges of your tongue have a scalloped pattern? So these are pretty much standard questions on validated questionnaires. And this is good. These are great questions. And you could just ask these questions and you'd be okay. It would be enough if you ask these questions. However, frequently, we don't take the time to ask these standard questions. Frequently, we get a new patient and we look at their chart and we look, there's something called the medical history and the dental history, and they always fill out they're on a medication or 2 or 3, or they see 3 or 4 doctors. So we're starting to get the idea that you don't have to even ask these questions if you see that they have a lot of medical conditions. You can kind of do an end around and just come up and surmise the fact that they have something going on in their bodies that's causing these problems. So we know that in the USA, 20% of our population has OSA. Now, that's just obstructive sleep apnea. The sleep-related breathing disorders actually include upper airway resistance syndrome, and that's a whole nother bunch of people. So it's probably a much larger number that can benefit from what we're offering them. People with excessive daytime sleepiness and 2 of the following 3 criteria: habitual loud snoring, witnessed apnea or gasping, and diagnosed hypertension. Those people have a 64% prevalence of moderate OSA. You should know that 6% of the people with OSA don't snore, so they don't necessarily have to snore. 93% of females, 82% of males with moderate to severe OSA are undiagnosed. So generally, if you have 1,000 people in your practice, you probably have 200 people, according to this, that have some sleep-related breathing disorder, at least 200 people, and 90% of them, that would be 180 people, don't even know they have it, and you can help them. So with scalloped tongue and BMI greater than 25, the odds ratio of obstructive sleep apnea increased to 4.74. Children, neck circumference, height ratio, this is just another metric, greater than 0.25, increases the odds ratio of AHI greater than 2 to 3.47. Okay, so you want to know, like, if you look at their neck circumference to their height ratio, this is just another data point. You want to know, does that increase the odds of them having AHI over 2? And with kids, you know, an AHI of 2 or 3 is significant. Snoring males with a waist to height ratio greater than 0.55 is an independent predictor of an apnea-hypopnea index greater than 15, or an odds ratio of 6.6. CPAP pressures over 10.5. That just differentiates between responders and non-responders. And in the book, you can find all the references for this. From age 40 to 60 to 60 to 99, the odds ratio of having AHI increased from 15, increased to 1.7. So if they have an AHI greater than 15, it's twice as much when they go from the 40 to 60 age to 60 to 99. So the older folks, they have twice as much likelihood of having an AHI greater than 15, which would put them in the moderate category. Snoring increased excessive daytime sleepiness 5-fold, and that we're going to refer to that as EDS. Habitual snoring with no OSA, that's AHI below 5, is associated with a 3-fold increase in motor vehicle accidents. And also smokers, we all know we counsel our patients not to smoke. They have a 4 to 5-fold greater risk of OSA than those who never smoked. So we should test them. Chapter 2 in the book. So that's just the standard questions. And again, if you want any of those statistics, they're all cited in the book in the back of the chapters of each chapter has the citations for all those percentages. The cardiology questions, this is the way this whole part 1 is laid out. They're on the left here. Do you have high blood pressure or take medicine for hypertension? Have you been diagnosed with CAD, stroke, congestive heart failure, AFib, or heart health issues? Do you have a pacemaker or do you have elevated total cholesterol levels? And why do we ask those questions? And these are the reasons we ask those questions. There's a section in each chapter called the fast facts, and this is exactly right out of the book. These are the fast facts. We know that OSA is an independent risk factor for development of hypertension. And within the hypertensive population, 30% have OSA. So you're not bad off if you test every patient that has hypertension. You're going to get a third of the people there are going to have OSA. They have impaired endothelial function. They have also in the drug-resistant hypertension, very important. If you see a patient on 3 drugs for hypertension, the prevalence of obstructive sleep apnea is 96%. That's for men and 65% for women. So severe OSA patients have 5 times the risk of CV mortality. 62% of stroke and transient ischemic attack patients studied had OSA with AHI index higher than 10. So stroke patients, you should really test. I'm not going to go through each one of these, but also you should recognize that an AFib cohort a study reveals 42 to 81% have obstructive sleep apnea. So if a patient comes in next week and they have AFib, or they're wearing a Holter monitor, or they know they have AFib, I think you should test them, because you know that based on these studies, up to 81% of them have obstructive sleep apnea, and there's a reason for that, which is going to be the next slide. If they have coronary artery disease, 37% have an AHI over 10. Angina patients, 30% have OSA. Patients with congestive heart failure, you're not going to see a lot of them, but 80% have OSA. Pacemakers, 59%. They have a pacemaker. You have to ask them about their sleep and their airway. Non-dipping hypertensives, that's people that don't dip down at night. They don't have a decrease in their blood pressure at night. Normally, when you go to sleep at night, your blood pressure goes down, but some people, it doesn't, and that's because of sympathetic activation, and they stay with an increased blood pressure all night long. So severe OSA patients, the odds ratio is 5.2 for cardiovascular mortality. Okay, severe patients, if you have severe OSA, you have 5 times likelihood of having mortality, a cardiovascular incident. 68% of patients with AV block have OSA, and the CIMT is significantly increased in just snoring patients. So if you snore, you're going to have a CIMT, that's the carotid intima media thickness, right where there's a bifurcation usually in the trunk on the carotids, where the external and the internal carotid splits. That's where there's usually some plaque, and that's really made a lot worse just from snoring, and there's inflammation from the snoring. And you can imagine with the vibration of those tissues, it's very, very close to that area. Dyslipidemia and insulin resistance, also increases arterial inflammation. So patients with OSA will have increases in lipid problems and increase in insulin resistance. So what are the underlying mechanisms of how OSA causes AFib? It's based on changing levels of oxygen and carbon dioxide in the blood. OSA induces repeated episodes of hypoxia and hypercapnia, which triggers chemoreflex sensors, enhances sympathetic activity, leads to tachycardia and blood pressure surges at the end of the apneic episodes. So you have tachycardia, hypertension, increases myocardial oxygen demand, but at the same time, myocardial oxygen supply is at its lowest because of no breathing and there's hypoxia. So these repeated myocardial ischemic events during sleep promotes atrial and ventricular fibrosis, which is a reactive reparative process and subsequently induces atrial and ventricular arrhythmias. It can lead to sudden cardiac death during sleep. So adding even more evidence for the case that OSA directly causes AFib, researchers found that CPAP use cut the risk of AFib in half. So that's just another way to view it. So if you treat the problem, the AFib gets better. So now we go to the pulmonary question. And in pulmonology, the 4 or 5 questions that I ask are, have you experienced difficulty breathing during the day? Do you have shortness of breath, even with mild exertion? Have you been diagnosed with COPD, asthma, or pulmonary hypertension? Is asthma worse at night? Or do you have a chronic cough, either dry or productive? That's right on the questionnaire. So we know within the OSA population, up to 20% have COPD. When they're together, it's called overlap syndrome. OSA does increase blood pressure of the pulmonary artery, which leads to pulmonary hypertension and possibly COPD. COPD can lead to peripheral neuropathy. And in OSA patients, pulmonary hypertension is found in 1/3 of the patients. I'm going to repeat that. In OSA patients, 1/3 of them have pulmonary hypertension. So patients with pulmonary hypertension, the prevalence of OSA is 80%. So if somebody comes in with pulmonary hypertension, they get tested, period. OSA patients have 3-fold the risk of asthma. Within the asthma cohort, 72% are at risk for having or developing OSA. In asthma patients, the odds of having OSA is 2.64 times higher than in the non-asthma patients. So anybody with asthma, we test. And that's a very simple thing. So how is this all related? Why do we ask those questions? OSA causes pulmonary hypertension. That's an increase in pulmonary arterial pressure in the lungs. The vessels that carry blood from the heart to the lungs become hard and narrow. And that the underlying mechanisms of pulmonary hypertension, there's 2 of them. You have hypoxia and the resultant vasoconstriction due to activation of the sympathetic nervous system. There's a nighttime drop in oxygen, also decreases the amount of nitric oxide the body can produce because of the decrease in the amount of oxygen needed to produce it. So it's nitric oxide is less bioavailable. And when you have a decrease or a vasoconstriction, you know that the only way to open the blood vessels up, or you should realize or appreciate that nitric oxide is necessary in order to open up blood vessels after a vasoconstriction. Secondly, pulmonary hypertension can occur as a result of hydrostatic mechanism due to increased left arterial pressure, the chamber where the oxygenated blood from the lungs re-enters the heart from the pulmonary veins. Increased left heart filling pressures it backs up the blood pressure and it increases the pulmonary venous hypertension. So there's 2 different mechanisms there that cause this. The Framingham study was done in the 80s and followed these people, wanted to find out what would lead to longer life. And as a matter of fact, they had no idea what they were stepping into here, but they found out that the larger the lung capacity, that equated to a longer life. Reduced lung function had a greater risk for all-cause mortality. So decreased vital capacity predicts cardiovascular disease. And the vital capacity is you take as big a breath as you can and then you blow out as much as you can. That's the vital capacity. And then we have gastroenterology. Moving on to chapter 4. Again, 3 questions I ask in gastroenterology. Do you experience heartburn or acid reflux at night or when you awaken in the morning? Have you or your dentist noticed erosions on the molars? Erosions are the cup-shaped lesions that they're not from wear. They're different, it's chemical. Do you take heartburn medication, either prescription or over the counter? So at the very bottom of the esophagus is a little valve called the lower esophageal sphincter muscle, and it separates the esophagus from the stomach. So that valve stays tightly closed to prevent the contents of the stomach, acid stuff, from backing up into the esophagus. But it can be breached by negative pressure. And those negative pressures in the lower esophagus occur during obstructive events because of the fact that the obstruction is above the level where the larynx meets the esophagus. So because the obstruction in the airway associated with the OSA is superior to that esophageal laryngeal junction, and the lungs continue to try to draw in air during the obstructive events, there's a negative pressure in the lower esophagus. So it is this negative pressure which acts to suck up the acid and other contents from the stomach into the lower part of the esophagus. And I have a picture for right brain people. People like to have an image. So this is the way we normally breathe. And you can see the path of the air. And that's an obstructive event, retroglossal obstructive event, and then causes negative pressure. And up comes the contents. This is the reflux that comes up. Gastric acid secretion increases during sleep, and it peaks in REM. And what do we know about REM? REM sleep, you have a lot of paralysis. Swelling and esophageal motility decrease. So you're going to have the acids coming up, and it just gets worse. If anybody's had an event where they have reflux, it takes a while for it to go away once the acid starts coming up. So within the OSA population, 60% have heartburn from reflux as compared with 20% in the adult population. So that's threefold. Within nocturnal GERD population, the prevalence of obstructive sleep apnea is threefold that of the general population. So we test anybody has reflux, anybody that takes medication for GERD, Prilosec or any of the proton pump inhibitors, we're going to go move ahead and suggest that we see a canary and that we'd like to do a sleep study. One study showed the patients with OSA and GERD, of those who use CPAP, 81% experienced normalized esophageal acid exposure. Patients with GERD have significantly higher risk of concurrent asthma. That's from aspirating these stomach contents. And as an aside, 30% of children that are diagnosed with asthma actually don't even have asthma. They're just aspirating this refluxate from the stomach. Patients with GERD have 2 times the prevalence of TMD. Ulcerative colitis associated with less than 6 hours and more than 9 hours of sleep. In an OSA group, 36% had IBS, approximately twofold what is seen in the general population. In the IBS group, 13% have OSA. It falls under the umbrella of functional somatic syndrome, which we can go into later. So these are just the first 4 chapters. And if you're interested in this questionnaire, which asks those same questions that I showed you, you can go to drlamberg.com, or you can actually call my office, and the girls can, in my office, they're happy to send you, fax you, or email you a copy of that questionnaire, and you can put it into your normal examinations. And so that's the end of part 1.
Thank you, Dr. Lamberg. Oh, just amazing. I'm just sitting here thinking as you're talking about this patient and that patient of mine. And over the years, just about every single one of my patients that's over the age of 40 is taking some type of medication for those things that you just talked about. And it's so interesting how so much of this can be related to sleep disordered breathing. So I'm so excited that the book, again, is Treat the Cause, not the Airway. Treat the Cause, Treat the Airway. Yes, Treat the Airway, not the Airway. Treat the Cause, Treat the Airway by Dr. Steve Lamberg. This has been part 1 of a 4-part series. So next week, we'll delve into other areas of medicine and how sleep disordered breathing affects neurology, how it affects your ear, nose, and throat, and other systems in the body. So we'll save that for next week, giving you this book in little bites at a time. But I would recommend highly that you buy it, and you can follow along with it as you're watching the podcast. So Dr. Lamberg, thank you so much, and we'll look forward to part 2 next week. This has been Health and Harmony Beyond the Beyond the Teeth. I'm sorry, were you going to say something, Dr. Lamberg?
Yes, thank you. Thank you for having me.
I'm sorry. This has been Health and Harmony Beyond the Teeth with Dr. Hal Stewart. Have a great week. Smile at somebody. They just may need it, especially in these times. At the time we're recording this podcast, just a couple of days ago, the horrible massacre took place in Uvalde, Texas. And this world needs people who care. Dr. Lamberg is one of those people. But this world needs people that will just take time to smile at each other and be kind to each other. So for what it's worth, try to do that this week. You may change somebody's life. So we're signing out now. We'll see you next week.